All right, we can get started. Um, I'm likely a new voice for all of you who have attended today. My name is Hunter Lingle-Isgrig, and I manage all marketing and communication efforts for the malaria portfolio at PATH, and have recently taken over communications for the G6PD Operational Research Community of Practice. Uh, I'm excited we could all gather today. I know there's a lot going on in the world and with our work at the moment. But we have a really exciting webinar and conversation planned for today. Uh, and I'll introduce our speaker shortly, as we'll be discussing training healthcare providers for point-of-care G6PD testing in Brazil. And Celia, if you wouldn't mind advancing the slide. So as you see, we'll have a few logistics as we've already started. We've got some exciting news, as the GORCoP now has a new website, which I'll give you a few bits of information on in just a second. And then we'll shortly introduce Jose. So yes, let's go ahead and advance to the next slide. So in an effort to better connect across the community of practice and increase opportunities for engagement, both for those who are currently a part of the GORCoP as well as those who may like to join the GORCoP, we built a website on path.org to enable access to the resources and materials and provide a central location that's external facing to get access to the box folder with all of our materials. And you can find that at path.org/GORCoP. And note, we are still hosting all of the materials in the digital repository on Box, and that still requires membership of the community of practice to gain access to those resources. You may access the box with a link that we've embedded on the site, but we still maintain that members-only relationship with that information. And so moving forward, should you like to access the box folder, if you are a member, you can access that through path.org/GORCoP. Note, we will still be communicating announcements and activities through all of the community of practice via email. I'll have an announcement at the end of the presentation showing how that's going to happen, as we also have a new template for newsletters and communication management system to help streamline and centralize how we communicate and collaborate with one another. But again, more will come on that. Just wanted to point that we do have a new website where you can identify access to the resource repository, as well as learn more about the community of practice and share it with your colleagues who may also have an interest in joining. But that's that. I want to save the bulk of the time for the webinar and conversation, and welcome Jose Diego de Brita Souza. So Jose is a PhD candidate and clinical lab scientist in tropical medicine at the University of the Amazonas State. He is currently working on clinical trials on the safety and effectiveness of alternative primaquine regimens in G6PD deficient patients, as well as implementation research specifically focusing on G6PD deficiency screening by malaria health workers prior to primaquine treatment in Vivax malaria endemic areas of the Brazilian Amazon. Jose, please feel free to add or massage that brief introduction. Thank you for joining us, and I'll pass it over to you.
Okay, that pretty much sums up. Is everybody hearing me well?
All clear.
Okay, so let's get started. As you already have introduced me, I'm Diego, and I will be presenting you the experience we had here in the Brazilian Amazon using the standard SD biosensor, this one that you can see on the right corner of the presentation. And I will make some comments as well regarding the care start in the period that we had implemented that as well. Okay, next slide, please. So in today's presentation, I will explain a little bit why we had changed from the CareStart platform to the standard SD biosensor platform, where we have performed this study, what type of professionals we used to implement the test, what kind of professors were responsible for screening the people, all the training materials that we produced and what was the structure that we used to train these healthcare professionals with those training materials. I will have some comments as well about, regarding the pharmacovigilance of acute hemolytic anemia, and also how we made sure that those healthcare professionals were able to properly and correctly perform the test and give a reliable results, with some comments at the end of what we have learned so far and what can be used in future studies, especially the tafenoquine study or the TRUST study. Next slide, please. Next slide. Okay, good. So to start, these two small municipalities in the Brazilian Amazon are our study locations. The first one you can see on the left is called Rio Preto da Eva. It's really a small municipality close to Manaus. It has about 24,000 inhabitants, a small number of mostly Plasmodium vivax malaria cases, and 11 health posts. The main objective of the SafePrim study was at first to evaluate the implementation of the Care Start, but then in the middle of the implementation, we had to change to the standard G6PD biosensor. So in Rio Preto da Eva, we had both the implementation of the Care Start biosensor and also the standard G6PD biosensor. The other municipality it is currently in our study is Mancio Lima. It's the westernmost city in Brazil, right in the border here with Peru, as you can see. There we have, it's 24,000, it's wrong, it's about half this population, it's the same as Rio Preto da Eva, but just to let you know, it's about 12,000, 13,000 people. We have a higher malaria caseload, including both Plasmodium vivax and also Plasmodium falciparum, and also a fraction of that is composed of mixed cases. In there we had 8 malaria health posts, and there we are only implementing the standard quantitative G6PD test. Next slide, please. So to start, I already have presented, I believe, I don't know if it was this year, maybe last year, we presented the procedures we have to train the healthcare professionals to use the CareStart platform. It is something similar to what we will discuss today. We had to make some adjustments and some specific activities, but it was overall really similar. You can see that in the period of the study, last year it was from February to December, we had a total of 40 deficient and 118 normal results that were screened into the malaria routine program of the municipality, that is Rio Preto da Eva. And from those, we were able to confirm 33 deficient results and also 62 normal results. For these samples, we had both quantification and also genotyping. And our results show that although the CareStart was really specific, it got all the deficient patients you see here, those 4 black dots. But on the other hand, we had a low specificity. So this means that a lot of people here, you can see on the right column of the graph, where you can read the CareStart deficient, all of those were classified as G6PD deficient on the CareStart, but only 4 were confirmed both with a point of care quantification and also through genotyping. So that's one of the main reasons we had to change from the CareStart to the SD biosensor, because of ethical reasons, of course, and because this high number receiving the weekly primaquine treatment may account for an increase in the malaria caseload because of low adherence, and also because the treatment is very long, it's 8 weeks. So sometimes the treatment cannot be supervised. It really depends on the healthcare professional's role in each municipality, so it varies a lot. So sometimes it cannot be possible to guarantee that this treatment is supervised. So it reflects, of course, in the end, in the malaria caseload of that municipality. Next slide, please. So in the unified health system we have in Brazil, two specific type of healthcare professionals were chosen to be trained, specifically the ones that directly work with malaria or that may eventually work with malaria, but their primary occupation are related to something else. So on the left panel, you can see that we have the malaria control worker. Their primary occupation is on malaria control, diagnosis, and also providing treatment. They only work with that. And then on the right panel, we can see the community health workers whose primary occupation is to facilitate the access from the community to the health services of that municipality. But they have an important role in the rural areas because in the majority of the times they are responsible for providing malaria treatment as well. So that's why we chose both the malaria control workers and the community health workers. Next slide, please. So the structure of the training was divided in a total of 4 hours. The first question you might have is because why only 4 hours? It's because as we had used healthcare professionals from the municipality's routine, they do not work all at the same time. They have shifts. So in order to have most of these agents in different meetings, we had to have a small but precise training that could be able to cover all the topics from the related to G6PD and malaria. So you can see that a small fraction of the presentation was a really theoretic session. We have the data from the primaquine associated hemolysis and malaria that was occurring locally. We also explained about the test, the CVEP form, which is a national malaria report form that we have in Brazil, the importance of returning on the 5th day of treatment, and also a patient result card. All of these materials I'm going to show you later on in the presentation. And also at this time, we were able to provide some case scenarios in order to make them discuss using what they have, using some of the experience they reported in the previous qualitative research that we had performed in their same population. And we also had a Q&A time to answer some possible questions that they might have regarding the test, the procedure, and the patient counseling. After a small break, we had the biggest part of the training that was mostly focusing on hands-on experience. So in this hands-on experience, they were able to perform the tests. We decided to use only 5 healthcare professionals per structure. So we had different tables, and in each table, we had one instructor that was responsible for overseeing this supervised practice where the agents were able to perform the test, counsel the patients, and also to do everything that we had explained in the theory section. And to assess whether these healthcare professionals were able to reliably perform using that 4-hour training, we had a small theory test and also a practice evaluation that I'm also going to comment later on. And if they had passed in both of these tests, they had a small certification that they received later. Next, please. Here are some pictures that we had from the trainings. This is just for you to get a small perspective of what happened. So on the left photo, you can see that it's a theory session. So we had, it really varied between the municipalities. In Mansulema, for example, we tried to get 20 healthcare professionals per day. So this way we could do only one theory session with everybody. And then for the supervised practice, we divided them per stations. And for each station, we had one structure. As you can see here on the right photo, this girl, Laila, in the purple shirt, she's one of the instructors. She's showing everybody the materials before they started the actual supervised practice. So all of these healthcare professionals on right were able to do the test at least once in each other, using each other's samples, using fresh samples in real blood. Next slide, please. So what did we use as training materials? We tried to base ourselves using the WHO guideline they have on G6PD testing. So we produced a test procedure folder that is a 4-page folder that they can have all the information regarding the test, the procedure, result interpretation, storage, and everything that is related to that test is provided in that test procedure folder. We also had a CVEP form that is a form used in Brazil to report the malaria cases, an instruction folder that indicated how they could fulfill that form. We also had a pen and a blank paper for notes. So this is a kit that was provided for each healthcare professional. Other materials were shared, which means they were either presented in the slide. For example, the training video we recorded, we used the same video that MMV produced for the tafenoquine study. We had also the case scenarios that would show them, would present them, and we would create this discussion within the healthcare professionals group. And we also showed the patient results cards. And for the practice session, we had all the materials necessary for the sample collection and test procedure. We decided to use fresh blood samples from the healthcare professionals because this way they could have a real experience performing the test. For the ones who know the procedure of this test, especially using the controls, we can see that there are small differences. It's not the same way that we have to handle as a real blood. So we decided to use fresh blood samples from each healthcare professionals. They would usually make pairs and one would take the sample from each other, and we had no problems with that. It was really overall well accepted. We also had a training evaluation form that we were interested to know whether that training was sufficient, whether the training was good in their opinion, about the time, about the materials, about the presentation, about the structures. So we have everything that we needed to know about those training structures. And we also had the theory, and then which was followed by a practice test. Next slide, please. So this is one of the training materials. I apologize for you because it is in Portuguese, but after today we will have all these materials shared with you so that they can be translated into English and everyone can use those. This is a poster. It was really interesting and was one of the materials that they really liked. They liked the most because that's something we could fix that on the wall, and they would look at that in case they had any doubts about the procedure. So it's, I don't know the size I have, but I think it's an A3 paper. So it's really big, and we fixed that on the wall. Next slide. Next slide, please. This one is the test procedure folder I mentioned to you. It's a 4-page procedure folder. This one is the front page. We have everything about the test, what's the test for, how to store, how to transport, what must be remembered. And here on the left side, we can see that we have an algorithm of treatment, depending on the result of the test, what treatment they will take, and what they have to do with every patient after treatment is provided. Next slide, please. And here is the inside of the test procedure folder. This part was, we got from the materials provided by PET. It's basically the same. We just had some minor language adjustments because it was really good. And the healthcare professionals really liked this part because it's really direct, concise, and has everything that they need to perform the test in case, for example, of those agents that perform active surveillance visits, for example, where they go to the patient's home to get the thick blood smear, and then they also had to get the G6PD results. So in case they have any doubts, they can consult that test procedure folder on site. Next slide. So this is the cutoff point that we used for the SafeBrain project. We use this 4.0 baseline, so which means that if a patient that equal or higher than 4, the patient could use daily Primaquine, and less than 4, the patient could not use daily Primaquine and thus would use weekly Primaquine. We had a lot of discussion while preparing the SafeBrain protocol on how to teach them to approach these patients, especially regarding a deficiency such as the G6PD deficiency. That's a very strong word here in Brazil. So when you say, I always talk to Renata from Trust that when we say something like that a person has a deficiency, that's something that they get really afraid. So we thought the agents so that they could use either they can use daily Primaquine or cannot use daily Primaquine without entering in too much detail about family counseling and about the specifics of G6PD deficiency. So if a patient had higher or equal than 4, use the standard treatment, and less than 4, this patient would use weekly Primaquine. And this cutoff points, just in case you want to know, it's equal to about 60% of the adjusted mean male median in our population. Next slide, please. This is one of the patient result cards. So whenever a healthcare professional performed the test in a patient, in a malaria patient, of course, they had 2 options to give to the patient. One green card, when the patient could use daily Primaquine, which means it's a normal G6PD result, and a red patient card when we had a different result, which is a deficient result. And in this card, we had all the information necessary for the healthcare professional to get without having to perform an additional test. So once a patient does the test for the first time, if this patient has a new malaria episode and return to that unit, only with this card, he is able to get the date from the test, as you can see in the lower half of the patient card. We had the G6PD result, the health post, and the agent that was responsible for performing that test. Other information that you can see in the table is the date of the malaria diagnosis, the results of the thick blood smear, the treatment, and the day that this patient should return for a thick blood smear. It's basically a pharmacovigilance visit that we will talk a little bit later. Next slide, please. This is the red card for the deficient results. It's basically the same thing that the green card has, but here you can say that there is this message, the result for the Primaquine test, this patient has done the G6PD test and cannot use daily Primaquine. So just by the color of each card, the healthcare professional would be able to provide treatment for a patient that has undergone the G6PD test. And on the back of the upper half of the card, you can see that there is a small drawing of a person with yellow skin, breathlessness, and dizziness. And we also have this drawing showing what is what we call a Coca-Cola colored urine, so that this patient could take a look of the signs and symptoms. They were advised to be vigilant of the signs and symptoms. And in case of any of those, they had to look for a specialized referral center. for treatment and also investigation. Next, please. Okay, so that was basically the part that we trained specifically to get the G6PD result and also to provide treatment for those patients. So what we had more specifically towards pharmacovigilance and patient counseling. So in general, all the healthcare professionals were trained to follow this small script. So for each patient, they had to always mention that those patients had to return on the 5th day of treatment because it's somewhere where this patient will have a peak of hemolysis. So the peak of signs and symptoms, this is about the day that this patient will feel the worst about a possible case of primaquine-induced hemolysis, even if this patient had a normal results. So all the G6PD deficient and all G6PD normal result patient had to come back on the 5th day of treatment. Of course, that many of those patients never returned because in the Brazilian Amazon, the geography of the areas hindered these returns. So patients that were more likely to return to those visits were those who were in fact feeling something related to the primaquine associated AAA. The second thing that we're taught to always advise those patients were to monitor the urine color, especially if it was black or coffee-like or Coca-Cola-like, and the yellowing of the eyes and skin. And in those cases, they should report and return to the health post immediately so those healthcare professionals could refer them to the state specialized health unit. So in Manaus, we have the Fundação de Medicina Tropical, and in Manso Lima, we had another specialized referral unit so that those patients could be referred. And the last thing was that they should have always mentioned that these patients could bring the malaria card so that a new test was not performed and this patient could not have its finger pricked every time they had a new malaria episode. So this is basically the script that these healthcare professionals had to follow to counsel these patients after the test, and they also had a small script so that they could follow before the test. So they had to explain what was the test for without entering in too much specifics of the G6PD genetics and results. Next, please. And here is actually one of the slides of our slide set used in the presentation, where we actually explained why is the thick blood smear on the 5th day of treatment for. So it was basically to monitor resistance to see if that patient had any positive blood smear by day 5 of treatment. And most importantly, to monitor the signs and symptoms of primaquine-associated hemolysis. And here you can see the dark urine. That's actually a photo of a patient we had in Manso Lima, and the photo of the yellowed sclera of that patient, and also those other symptoms that might be related to primaquine hemolysis. And that if any of those were present, these healthcare professionals had to enter that data into the CVEP-4, which is the National Malaria Report form, and that patient should have been referred to the nearest specialized health unit. Next, please. And for the training evaluation, we had a theory test that was composed of 10 questions. These questions were related to basic questions of malaria, what types of malaria we had, what was the treatment for malaria, what was the treatment if a patient had a G6PD value less than 4, the treatment if it had a different result, what they should have done in case a patient presented some of those signs of hemolysis, it was a test to evaluate the basics, at least from what we had trained in that 4-hour training. And then after the theory test, these healthcare professionals had to undergo a practical exam. This exam had 14 items, but only 9 of these items were mandatory for that agents to have a minimum passing grade. So they had to have at least 90% of those mandatory items. The other items were items that were related to the procedure, but that if was not present, that could not be a problem because the result itself would mitigate the problem of the primaquine associated hemolysis. That is one thing that we discussed during some of the trainings. We had to do some small adaptations on this test, and then we decided that only 9 of those 14 items would be mandatory, while the accessory items would be just to evaluate other items that could be improved in the practice session in future trainings. So we use a minimum passing grade of 90%. That's something they already use here. We have the local training guidelines, which are provided by LACEN, which is a central laboratory that coordinates all the laboratories in the state. So in order to make it similar, to use the same structure they have, we used the 90% minimum passing grade. So a healthcare professional was considered able to perform the test and was given a certification if they had at least 90% on the theory test and 90% on this practical exam. And in those cases where we could not get the minimum passing grade, an individual training was made with that healthcare professional and also a retest to check their proficiency over this new training. Next, please. And here is a sample of the supervised practice and the theory test. It's not all the test, it's just a small part that you can see where we have a couple of questions related to the procedure. On the left side, you have the supervised practice test. So while the healthcare professional was carrying the test procedure, the instructor was overseeing the practice and was marking yes or no for each of these topics that was graded 1 point. And the theory test was given to each of these healthcare professionals. They would fill this test, put the names, identification, and then they would return to the supervisors present on the day of the training. Next, please. Here are some of the results we had using this approach in Mansell Lima. On the upper part, you can see the graph for the scores for the theory evaluation, and the lower part, you can see the scores for the practice evaluation. So here you can see that most of these healthcare professionals were able to have the minimum passing grade with only 1 session of training. But there were small differences between Mansell Lima and Rio Preto da Eva here in Amazonas, because there we had a higher malaria caseload, although a very small population compared to Rio Preto da Eva. And also we had a younger profile of healthcare professionals. So they were able to get the information really easy. They were able to perform the test with minimum information. Next slide, please. And here in Rio Preto da Eva, that has a small malaria caseload, and we also had a higher amount of other healthcare professionals. The training had some additional sections in some healthcare professionals. As you can see, the theory test was generally well accepted, while the practice test, we had a higher amount of individuals that needed a retest. That higher amount of individuals was mostly from actually two units in Rio Preto da Eva that had not reported any malaria case in the previous period. So from February to December, those 2 units had not reported any case of malaria, and those were the units that we had the lowest scores on both the theory evaluation and also the practice evaluation, as you can see. So we had to have a retest and a retraining, individual retraining with all of those agents, and then most of them were able to get the minimum passing grade with just a second round of evaluation. Next, please. As for the pharmacovigilance network that we used here, we have, we kind of, Marcus liked to talk about the Swiss cheese model, so I just got and put here in the slides where you can see that the different slices of this cheese, saying that way, we have many barriers that we can use here for the Safe Brain project. The first one is the testing itself. So when a patient comes to the malaria post, the healthcare professional would perform the test. After the test, independent if it was normal or deficient, that patient should have returned on the 5th day of treatment. So the healthcare professional would ask for any signs and symptoms of hemolysis. And in case a patient does not go back to that health post, but instead go to a different unit or go straight to the specialized referral center, we have this program, we have this strategy that we can cross-match the data from that individual from the National Malaria Database to the inpatient database. Here in the Amazonas and also in the Acre state, we have a statewide inpatient data. So we use some of the variables that we have of that patient, and then we match these different databases to check whether that patient that had a positive result on that day was hospitalized for any reason in the following 15 days. That's something that we are still perfectioning, because that is something that is related to the state government. So things sometimes are slow, the access to the databases, the update of that database as well. So something that we are still perfectioning, and that's something that we hope to have also with within the CareStart manuscript that we plan to submit maybe still this month. Next slide, please. As regarding how we supervised all of this practice that we have trained the healthcare professionals, in each municipality we have a field supervisor that is from the study, but who is responsible for overseeing all the activities related to the study. So they have these supervision questionnaires, which are basically REDCap online data entry forms. They follow, let's say that that is a specific day that the supervisor goes to that unit and will follow the routine that day, and through the supervision questionnaires, the supervisor will answer a couple of questions regarding the test procedure and patient counseling. So this way we can monitor whether the healthcare professionals are performing everything they need to have the G6PD testing and counseling. And also the supervisor, in the case of the standard G6PD quantitative test, is also responsible to perform the quality control on instruments. So he is the one that takes all the control samples, and following the municipality's guidelines for supervision, let's say at least 15 days or a month, it really depends on the municipality. So we use the same strategy to have all of these machines collected and have the quality control performed in all of them. So we have the high control, the high level control, and the low level control. And we also have the check strip that are mechanisms that we use to say that those machines are actually working as expected. Next slide, please. So here are to finalize the presentation. We have some lessons learned that we observed during the SafePrint trainings. Renata, I don't know if you all know Renata. She is from the Trust study, and she was the one helping me with these trainings. She managed to help me a lot with this training. So we had many discussions about what could be adapted for the training. So it was a very dynamic process. After each section of training, we discussed something that could be improved, and then we had some small modifications until she could get to something that could be expanded to a higher level, especially for Manaus and Porto Velho, that are the ones who will be receiving the tafenoquine in the upcoming months. So it was a really nice time because we could discuss and provide these lessons learned from the SafePrint trainings. The most interesting thing that we observed was that all of these mechanical parts, the test procedure itself was not the problem as we had expected. We could observe that the most difficult part for the patients was the pre and post counseling, which refers to what's the test for and how the test works, to the treatment that they will provide, and also the counseling for signs and hemolysis respectively. So this was the part that was a major issue. We could observe that each one had a different way to counsel properly a patient. Some of them remembered just a couple of the things of those scripts that we use. Some of them used something that were not related to the G6PD testing, but they tried to get that into G6PD testing to make the patient understand what's the test for. We could also observe that all the training materials and the training were overall well accepted. That was observed in the evaluation, the training evaluation forms that we had. And also we saw that as for the most practical part, that something that the patients forgot to match was the chip code that was provided for the instrument. But since all our tests that we received are from the same batch, they are all using the chip code. So it's the chip code for the same for the whole batch. That may not be a problem, but that's something that can be improved in upcoming trainings, especially for the trust trainings, to find a way that these patients always remember to match the chip code number to the one that is shown on the screen of the instrument. Next, please. And lastly, some of the refresher trainings should be implemented in those municipalities, because at least here in the Brazilian Amazon, we have municipalities with different malaria caseloads. For example, Mancio Lima has a higher caseload, while Rio Preto da Eva has units that have never had notified a malaria case. So something we are discussing with the local authorities is when those refresher trainings will be implemented in those municipalities. But it's almost for sure that we will follow also their guidelines for refresher trainings for microscopists. That's the closest we have for trainings for everybody. So maybe every 3 months or every 6 months, we will have these refresher trainings to assess their proficiency over time and see how much of the training we had on the first basis was actually remembered for them, and so that we can adjust these refresher trainings and timelines between the municipalities. And also, training for other healthcare professionals should be considered, especially because of physicians and nurses that are related to the malaria routine, but are not somewhat familiar with the primaquine-induced hemolysis. So that is something to have into consideration, so that all these patients are aware of the flow in the routine of a patient that might present some signs and symptoms of hemolysis. Next slide, please. And lastly, I'd like to thank all these institutions that were crucial to discuss many steps of our trainings, especially the BMGF path that provided a lot of the training materials that we had used, and also the MMV, who is constantly discussing with us the strategy to train those healthcare professionals and providing insights on training materials and training strategies that we have been using every day in our study. Next. And here is my contact information in case you have any further question, any further query regarding the data or specific details of this presentation. I think today I will be able to send all the materials we have, including the materials for the CareStart and also for the SD biosensors, so that they could be shared within the community of practice platform, and also the video trainings that we can post there and might be used someday for any other study. Thank you, everybody.
Thank you very much, Diego. We'll be sure to keep a lookout for those materials, and we'll communicate it out to the larger community of practice once those are available. Diego, I have an initial question for you before we open up the floor, and that is, could you give us all a little more details or information around what the TRUST study is for those who may be unfamiliar?
Mm-hmm. So the TRUST study is basically an expansion of the SafeBrain study, but the TRUST includes the tafenoquine. In the SafeBrain, we only have daily primaquine and weekly primaquine, while in the TRUST study, they will have the primaquine, but also the tafenoquine. So they will have to train healthcare professionals from bigger municipalities, as for Manaus, as for Porto Velho, that have much more healthcare professionals and many more units. So the TRUST study is basically an expansion of the SafeBrain with all of those procedures, but with slight modifications to suit some of the operational aspects, specifically to Manaus and Porto Velho. But the instrument is the same. The threshold will be a little bit different as well, so because they have to make sure that a patient receiving tafenoquine has no chance of developing primaquine-induced hemolysis, and therefore they will have to have some adaptations on the training materials, the slide set, and any other material related to the SafeBrain.
Great, thank you so much. And with that, we'd like to open the floor for a few questions. So if you have a question, please unmute yourself and we'll go from there. And if you do unmute yourself, please state your name and the institution you are affiliated with, please. Let's see, I see Angel has raised her hand. Please go ahead.
Yes, good afternoon. Thank you very much for the presentation. Yes, I have two questions. My first question is, what about the recurrent episodes? Yes, and I think that my first question is that all the new cases are tested or no for G6PD, even if they were tested before. This is my first question. And my second question is, what happens when you have somebody that come with a red or a green card, yes, and the test and the new test is different, the result is different? How can you proceed?
Okay, thank you. That's a really interesting question. So when the patient is tested first, and he will have this card, a new testing is not performed. It will only be performed if this patient does not know or does not have this card, and then the healthcare professional would obviously have to perform a new test. That's something that happened in Rio Preto da Eva because we first implemented the CareStart test, and then we had a different patient card that we will share with you as well. It was a gray card and a purple card. The purple card was for the normal results, and the gray card was from the deficient results. So in those cases, in Rio Preto da Eva specifically, when a patient came with the old card, they had to perform a new test with a quantitative test, and then a new card was provided, either red or green. And if the result was different, a new card according to their result was provided.
Okay, thank you very much. I forgot to say I work for the Université Catholique de Leuven in Brussels. My question is, it was a learning process, or you schedule or program it like that since the beginning?
Can you repeat the question, please?
Yes, I want to know if, for example, this algorithm that you explained now, yes, you learned it with the, or you programmed these activities or this algorithm since the beginning?
We programmed, the first one we wanted to implement only the care start, but then we saw that we had some high amount of false deficient results, and then we had to change. So it was something not programmed, but that was something that we were able to handle during the process of that study. Does that answer your question?
Yes, thank you very much.
Okay, thank you.
Thank you for that. And before the next question comes, I would also like to encourage people to ask their questions in Spanish or Portuguese, as we have a few folks on the line who could support with translation.
Hi, this is Emily from PATH. Diego, thank you so much for this presentation. I think it is just really incredible how comprehensive the work you've been doing is. I wanted to ask just sort of your take on what it was like to transition the health workers that you had trained from one test to another. Because I think some other countries are in a position of maybe having recently trained their health workers on how to use the qualitative test and thinking about what it will entail to take on the quantitative test, and were there things that were more complicated or less complicated than you expected, or just things that went differently than you might have thought?
That's a very good question, Emily. We had this experience in Rio Preto da Eva. Although I did not talk about the qualitative analysis we have done this qualitative research before the trainings and also after the implementation to check whether these healthcare professionals accepted and whether what patients felt about the testing. And something that we heard a lot during the qualitative interviews is that although the test was easy to perform, it was very difficult for them to check the results. And as for the care start, at least in my experience in laboratory, the result was much more easier to see than compared in the field, that the results were much more fainter than what we saw in the laboratory. And during these qualitative interviews, they mentioned that they did not trust the test because sometimes they associated the G6PD test with the previous malaria test they had worked on. And then that test did not have a good sensibility and specificity. So for this association, they did not trust a lot in the Care Start G6PD test. But as for the quantitative machine that we have, it was totally different. They had a first impact at the beginning, but it was something for them that was very easy, very smooth to learn, something compared even with the Care Start. But that's something, that's it. That was what we observed when we transitioned between the Care Start to the quantitative biosensor. We did not see major problems, but we heard a lot of complaints about the Care Start in terms of subjectivity of the interpretation, and also because per association with previous malaria tests, they would associate the G6PD testing with this malaria testing that they did not trust.
Great question. I believe Paola had her hand raised next. And so Paola, if you'd like to ask your question, we'd love to hear it.
Control Program, Minister of Health. just was thinking about if it's already possible to imagine the difficulties and challenges that you can imagine if in case we have to train all the Amazon region and also outside Amazon region, but mainly our Amazon region in using these tests. Thinking that depending on the results or the studies that are being done and are being planned.
That's a good question. I forgot to mention during the presentation that we will also be confirming the results from the quantitative data. So a sample of patients with the normal results and a sample of patients with the deficient results will all have samples collected to be genotyped, as we did for the CareStart platform. But for sure, during these trainings, we saw that some of the aspects need to be adapted according to the population that you will provide these trainings. We could see this difference using the agents from the healthcare professionals from the Rio Preto da Eva and also from Mancio Lima. Since we had this younger population in Mancio Lima, it was really easy to go through the G6PD testing. But in Rio Preto da Eva, we had this small impact at first, this, how can I say that? This difficulty related to the procedure and especially related to the patient counseling and other procedures that might be related to the testing. So that is something that I was even discussing with Renata when using the test for Manaus and Porto Velho to consider these differences in populations and be able to manage these differences per training. So the idea in those cases were to divide these trainings per sanitary regions, per units, that you can have a more individual approach, but also efficiently and properly training all those agents.
That's great. Thank you, Diego. We have time for one more question, and I apologize for those who have more. You can please feel free to submit those over email, and we will be sure to follow with those up quickly. But I believe Jane, and apologies if this is the wrong last name, this is what I'm seeing on the screen, but Jane Cunningham, I believe I saw your name as the next person with a question. So please feel free to unmute yourself and fire away.
Hi, thanks for a great presentation and some really interesting results. I guess mine's more of a comment, or well, I guess I have one question and then just a few comments. So I just was, if you could clarify, what did you actually tell the patients about their G6PD status? Because you've mentioned you mentioned initially that the response of patients to being called deficient was quite sensitive, and then there was a decision just to change the dosing. And so, yeah, so that's my primary question, is just around what did you actually say about their G6PD status and what kind of counseling was given? And then I myself have organized just one training workshop for this test as part of an emergency response in Djibouti, and it was over 16 hours, but many of the components that we reviewed were around anemia, so how to use the hemoglobin readout on the machine. Also, we included the training on controls. There were also there's the recommended thresholds in the manufacturer instructions have different thresholds for males compared to females, and so that absorbed quite a bit of time, whereas I see with your training, because you had local population data, you were able to use a single threshold. And then also the troubleshooting piece took a fair amount of time. So I don't know if you can just answer my first question, then maybe give any kind of comments you can of issues around controls, anemia, troubleshooting arose during your training sessions. Thanks.
That's a very good question, Jane. About your first question, we usually talk with the healthcare professionals so that they could have this conversation with the patient without having too much details about the genetics of G6PD deficiency. So let's say that in general, these healthcare professionals would refer to that patient in case of a deficient result, that patient might develop this reaction when taking daily Primaquine. Such reactions included yellowing of the skin, yellowing of the sclera, dark urine. He would basically go over the major signs and symptoms of hemolysis, and then would explain that that patient must not have the daily primaquine, and instead should take this weekly primaquine, because this way the patient is less likely to feel anything. But in any of those cases, that patient should return on the 5th day of treatment to see whether this patient is feeling anything or is showing any signs and symptoms of hemolysis. As for the second part of your training, that's right. If you were to include some of this data, especially if you have to talk about intermediate results, that it's going to take a lot of time. And something that we advise Renata to do is, because in our case we have our only supervisors, if we try to expand that, for example, in the Brazilian Amazon, we will have to use the structure that's already provided. So for Manaus, for example, we already have the local supervisors, and the trainings for those supervisors will need to be much more deep, much more wide regarding the G6PD testing. And in this case, it is more likely that you must include topics about epidemiology, specific counseling, and all of those details that were not provided in the trainings for these healthcare professionals.
All right, thank you very much, Diego. Celia, that concludes the program for today. Celia, if you don't mind advancing to the next slide. There's just some wrap-up housekeeping efforts that I want to make sure you're keen to. In addition to our new website, we also will have a new email template and email management platform where we'll be disseminating information about attending upcoming webinars, as well as announcing new materials such as those that Diego discussed. When we launch that, we'll be forwarding that communication from the new email management system from the GORCoP email that you're typically responding to, just to ensure that this doesn't go to spam and that we're all on the same page in regard to where communications will be coming from moving forward. Of course, any questions you have, you are always welcome to continue communicating to the GORCoP email you currently have. Next slide, please. And lastly, I wanted to share that we do know exactly what our next webinar will be about, and that's on field testing of tafenoquine and G6PD materials in India and Brazil with Maud, excuse me if I don't say your name correctly, Maud Lugand and Melanie Larson from MNV. And so those details will be shared shortly via email, as well as on the new website. And with that, thank you very much for participating. We are excited to host this conversation. Thank you again, Diego, for presenting with us. If you have any questions or follow-up, please email gorcop@path.org, and look forward to hearing from us in the near future with the recorded webinar. Thank you very much.